This video describes the hypogonadism in the male, the diminished function of the testes resulting in reduced or absent secretion of testosterone and or impaired spermatogenesis is hypogonadism. It can occur during fetal life, before the puberty, or in adulthood with different clinical outcomes. So, if the testes are non-functional in the male fetus, that is termed as fetal hypogonadism, and in this condition, no testosterone is produced, and default sexual development is female, the internal and external genitalia both. Testosterone normally suppresses female organ formation and promote male organ differentiation. Thus, without testosterone, the fetus develops female-type sexual organs even if genetically XY. If a boy loses his testes before the puberty, it will result in a state of eunuchism. He fails to undergo normal male puberty. Sex organs remain infantile in size and function, and secondary sexual characteristics do not appear. There is tall stature. Clinically, the average man is slightly taller due to delayed closure of the epiphysis, and there are thin bones and weak musculature due to lack of anabolic effect of testosterone. The voice is childlike. There is no laryngeal enlargement. There is no presence of male pattern hair distribution in the body, and scalp hair is retained. There is no male pattern baldness. So there is lack of male body habitus, and the person remains with soft childlike contours. So fetal hypogonadism is it will lead to phenotypic female development, and before the puberty, the prepubertal hypogonadism will result in persistence of infantile genitalia. The person will be tall but frail body and weak muscle. The voice is childlike and absence of male pattern hair growth. If the person loses the testes after puberty, there is a regression of sexual organ but not a childlike state. The deep bass quality decreases only slightly since laryngeal changes at puberty they are persistent or permanent. Loss of masculine hair pattern, beard, chest, pubic hairs are reduced, and the skeletal muscles, the bone loses its thickness and strength due to loss of the anabolic effect of the testosterone. The muscle mass is also decreased, and the libido is also decreased, right? But it is not completely lost, especially if sexual activity had been established before castration. So this erection is still possible, though less frequent and less rigid. The ejaculation is rare since accessory the sex gland such as seminal vesicle, prostate, they also regress, reducing the semen production, and there is loss of testosterone driven psychic drive that weakens the ejaculatory response. So partial regression of the sexual organ occurs when there is loss of testes after puberty with slight regression of the voice, loss of masculine hair, decreased bone mass and muscle bulk, or reduced libido, but erection is possible, but ejaculation is rare. Another cause of hypogonadism in male is adiposogenital syndrome, that is also termed as Froelich syndrome or hypothalamic eunuchism. So it is due to genetic inability of the hypothalamus to secrete adequate gonadotropin releasing hormone that lead to hypogonadism, because without gonadotropin releasing hormone, anterior pituitary does not release luteinizing hormone and follicle stimulating hormone, so testes fail to secrete testosterone and the hypogonadism eunuchism it develops. So this condition is often associated with the abnormality of hypothalamic feeding center. So it is also associated with excessive appetite and overeating that leads to obesity. So the clinical features are eunuchism, that is infantile sexual characteristic due to testosterone deficiency. There is obesity, uh, especially central or truncal, and absent or delayed puberty. The genitals are underdeveloped, and also the secondary sexual characteristics are underdeveloped, such as voice, hair, and muscles. They are underdeveloped. This adiposogenital syndrome is a form of hypothalamic gonadism caused by failure of gonadotropin releasing hormone secretion combined with hypothalamic feeding center dysfunction, leading to obesity and eunuchism. This table is summarizing the differences between the primary hypogonadism or testicular failure and the secondary hypogonadism that results due to hypothalamic and pituitary failure. So the primary hypogonadism is due to failure of the testes to produce testosterone or sperm despite adequate stimulation, while secondary is due to failure of the hypothalamus or pituitary to produce gonadotropin releasing hormone or gonadotropins that are luteinizing hormone and follicle stimulating hormone. So in primary hypogonadism, there will be adequate luteinizing hormone and follicle stimulating hormone due to lack of negative feedback. Their concentration in the blood is increased, while in secondary hypogonadism, the gonadotropin releasing hormone, the luteinizing hormone, and the follicle stimulating hormone all are decreased. Testosterone in both of the condition is low, and the spermatogenesis is also impaired in both of the condition. The primary hypogonadism or testicular failure is seen in Klinefelter syndrome, that is a chromosomal disorder, and it is 47XXY. It is also associated with mumps, orchitis, testicular injury, and age-related testicular failure, while the secondary hypogonadism, the Froelich syndrome we have seen earlier, or adiposogenital syndrome, or the Kallmann syndrome, that is the result of gonadotropin releasing hormone deficiency or pituitary tumor or due to head trauma. The clinical feature for primary hypogonadism are small firm testes, infertility, gynecomastia, that is common, unified body habitus, and sparse beard and body hairs. While in secondary, there is delayed absent puberty, eunuchism, the sexual organ are infantile. There is obesity, especially in Froelich syndrome or adiposogenital syndrome. Anosmia in Kallmann syndrome is seen, and it is also associated with low libido or infertility. The primary hypogonadism is associated with tall stature with eunuchoid proportions. Their limbs are long due to delayed epiphyseal closure, while the secondary also shows same pattern, but often it is associated with hypothalamic features such as obesity and other endocrine disturbances. The treatment for primary one is replacement of the testosterone plus fertility therapy if needed, and gonadotropin assisted reproduction, while the treatment for secondary hypogonadism is testosterone replacement, pulsatile therapy by gonadotropin releasing hormone or gonadotropin for induction of the fertility. So this picture, this is depicting the clinical appearance of a male patient with hypogonadism, especially the adiposogenital syndrome. Uh, the key features that are visible are obesity. There is noticeable accumulation of fat in the trunk and abdomen, giving a feminized body contour, and the genitalia are underdeveloped. The external genitalia are infantile in size and consistent with the lack of testosterone. The secondary sexual characteristics are also lacking, and there is no beard, mustache, or body hair, and no male pattern muscles. The arms are soft, thin, and the shoulders are not broad or masculine body build. The body habitus suggests failure of puberty due to testosterone deficiency. It is caused by hypothalamic gonadotropin releasing hormone deficiency that lead to decreased luteinizing hormone and follicle stimulating hormone. As a result, the testosterone is decreased, and it is associated with feeding center dysfunction that will lead to hyperphagia and obesity. This image is focusing on the genital region of the male with hypogonadism consistent with adiposogenital syndrome or Froelich syndrome. The penis is micropenis. It is markedly underdeveloped, indicating lack of testosterone stimulation during puberty, and there is uh, a small or poorly formed scrotum, suggesting testicular atrophy or failure to mature. There is excessive fat deposition. The suprapubic fat pad partially obscured the genitalia, a typical feature of obesity associated with hypothalamic dysfunction. The pubic hair are also lacking, that reflects the androgen deficiency. So this infantile genitalia is an obese male, which is characteristic of secondary hypogonadism due to hypothalamic gonadotropin release hormone deficiency. This condition aligns with Froelich syndrome or adiposogenital syndrome. Thank you for watching this video. If you have any query, please write in the comment box.